The information in this podcast is provided for informational purposes only. You should not use any information discussed in this podcast and related materials to make medical or healthcare related decisions. Always consult your physician or other qualified healthcare provider with regards to diagnosing and managing your medical condition. Any medications or treatments, including any discussed in this podcast, should be initiated and managed by a qualified healthcare professional. Welcome to Long COVID The Answers. Today's episode is called Breathing Difficulties in Long COVID. I'd like to introduce Professor Michelle Harkins. Professor Harkins is a professor of medicine at the School of Medicine at the University of New Mexico in the United States of America. She is the Division Chief, Pulmonary Critical Care and Sleep Medicine Co-Chief of the Adult Center for Critical Care. Professor Harkins managed many COVID-19 survivors during the pandemic in the Medical Intensive Care Unit. She continues to conduct research on COVID-19 and long COVID and plays an active role in Project ECHO, a telehealth program that provides real-time education and case discussions for community health practitioners for the management of long COVID in the community. Professor Harkins recently spoke at the Health, Education, Labour and Pensions, or HELP, Senate Committee on Long COVID hosted by Senator Bernie Sanders in the US in January 2024. Welcome, Michelle.
Thank you. Thanks for having me.
Michelle, do you have any conflicts of interest to declare?
I do not.
Okay. So around 1 in 4 adults who were hospitalized with COVID-19 and 1 in 6 not hospitalized experienced persistent breathing difficulties beyond 4 weeks after a SARS-CoV-2 or coronavirus infection. Breathing problems in long COVID can exist on their own or be part of multi-organ problems caused by the coronavirus directly or pre-existing or separate problems. Michelle, what are the common symptoms of breathing difficulties that a person with long COVID has?
I find most patients feel breathlessness, mostly with exertion, but sometimes even at rest. They may have cough, wheeze, poor sleep pattern, or even sleep apnea. Chest tightness and chest pain. Those are the most common ones that I see. And some of these symptoms occur for several weeks after the original COVID infection, but if they really persist beyond that 4 or 6 week period, then it's important to seek medical advice.
What causes of breathing difficulty are related to a previous COVID-19 infection?
Well, the main pulmonary manifestations from COVID are pulmonary embolism, or a blood clot that goes to the lungs, pulmonary fibrosis, which is scarring of the lungs, or a pneumothorax, a collapse of the lung, or a new reactive airways disease. We also see vocal cord disease or tracheal stenosis, especially if they've been on a ventilator for a while. And then there are a large group of patients with breathlessness and cough and chest tightness or chest pain without significant objective findings. And patients can have breathlessness for more than 4 to 12 weeks post their infection. And some also may have some dysautonomia, with tachycardia and palpitations with dyspnea, which really is probably POTS disease, which is postural orthostatic tachycardia syndrome. Some patients also have cardiac issues, such as tachycardia or myocarditis, that may cause shortness of breath as well. And then some patients have underlying lung disease, then got a COVID infection, and now have worsening of their underlying asthma or COPD, for example.
Great, great. And for our non-medical listeners, cardiac is heart. And could you briefly, I mean, we've talked about it in other episodes, but just in case somebody's watching this episode in isolation, what's dysautonomia?
Dysautonomia is where your heart rate, for example, may increase greatly when you stand up from sitting. It's a dysregulation based on your nervous system of getting palpitations or having blood pressure drop, depending on what you're doing. So it's where the normal nervous system changes and you have abnormal responses with your heart rate, for example.
Yeah, so and the way I like to understand it is that it's a dysregulation of your automatic nervous system, isn't it? Or autonomic, the bits of the nervous system that you don't actively control, like your heart, your breathing, all the brain does this automatically, so they become dysregulated.
Absolutely.
What are non-COVID causes of breathing difficulties that a person with long COVID could present with?
Well, patients could come in with shortness of breath from a variety of reasons. And so looking for other causes of shortness of breath on exertion, such as anemia. That could be a problem, a low blood count. Patients could have thyroid problems or just be really deconditioned from their COVID infection. And maybe they've had weight gain, and that can contribute to shortness of breath. And deciding whether these things were related to developing COVID or not, but looking for other things that may be impacting their ability to do their activities daily. The patients may also come in with a totally new thing like pneumonia or a new viral infection. So they may have more acute symptoms. And again, like I mentioned, underlying lung disease that may have gotten worse, but that might have been because of their COVID infection.
Mm. Yeah, so you always got to have your head on a swivel with this disease and not just tunnel in on any one thing. We've got to remember the broader aspects of medicine. That's what this is sounding like.
Absolutely, because you have to think like a good general practitioner and putting things in, always do a good history and physical. And is this something that is COVID related, or is this something that has developed in the long COVID patient, or is it something not related to that at all? So always doing your good basic workup and history and physical is key to trying to help sort these things out.
Excellent. What are the red flag or danger signals in the medical history that a physician should look out for, and what serious conditions would these indicate?
I always look closely at the vital signs and look for hypoxia, so low oxygen levels, especially with exertion, because that's important. That's something you can treat, one with oxygen, but you need to know why is that happening. Other more acute symptoms, sudden shortness of breath, sudden chest pain, hurting when you're taking a deep breath might suggest a pulmonary embolism or a blood clot that's gone to the lungs. Other chest tightness that worsens as you exercise or worsens as you're even doing minimal activity could be coronary artery disease or angina. So something we'd worry about having a problem with your arteries in your heart. They could become blocked and give you a heart attack, for example. If patients have very progressive shortness of breath at rest and exertion, that makes me wonder what's going on, what is happening, because usually symptoms start and then over time they get a little bit better in the long COVID patient. But if things are progressing, they may have a worsening scarring of the lungs. They could actually even have neuromuscular disease, something that has started that's new, where their muscles don't function well, or their nerves are not telling their muscles to function well. So a lot of other things that could happen, but the progressive acute symptoms that are new should make you concerned.
Excellent. What percentage of red flag conditions occur in long haulers, and in what time frame?
Well, I see patients discharged needing oxygen, but that usually improves over time, and most of them are able to wean off in about 4 to 6 months, sometimes a little bit longer. It was actually reported initially that patients that had COVID are at very high risk of blood clots and pulmonary embolism, that blood clot that goes to the lung. And some of the initial reports suggested this was an increased risk over the next 6 months to a year of about 25%. Now, that's been questioned. And so more recent data and other, what we talk about meta-analyses and looking at other databases have suggested that increased risk of a blood clot is actually really much lower. Still probably more than someone that did not get COVID, but really in that 2 to 3% potentially. In our post-COVID pulmonary clinic, we saw about 14% of our patients had a lung collapse. 11% had that stenosis in the trachea, or basically a scarring down in the trachea after they were on a ventilator. And about 20% in the earlier years did have a pulmonary embolism. But I think all of these complications have become less common, especially as our treatments improved for treating acute COVID. But we don't see as many of these severe complications or pulmonary complications in the more recent COVID patients because they haven't been hospitalized and they're not on a ventilator.
Yeah, so those more serious complications were those that were mostly hospitalized.
That tends to be true. Now, you can have severe pulmonary symptoms without hospitalization. I've seen patients that had the blood clot to the lung that were not hospitalized, or they had a collapse of the lung and had a lot of scarring in their lung 6 weeks after an infection where they were just at home. So it doesn't have to be severe disease, but those that were in an ICU and had severe disease are more likely to develop long COVID and maybe have more severe symptoms.
Okay, thank you. Are there any helpful investigations that a family physician should do for a long hauler with breathing difficulties?
Well, I think doing a good history and physical is going to help determine if you need to do further workup. That would include potentially pulmonary function tests where you're measuring the actual function of the lung, inhaling and exhaling. You might want to consider a chest x-ray. And always I measure oxygen saturations because whether they're sitting at rest as well as they walk around potentially in your clinic. I pay attention to their breathing pattern. Do they look like they're relaxed? Are they breathing normally per se? And sometimes patients, if you're not sure, you might want to do an echocardiogram or an EKG. That could be reasonable too, if your history pushes you in that direction. The ultimate test is a cardiopulmonary exercise test, which evaluates all causes of shortness of breath, but this is not practical. I don't even order it very often in my pulmonary patients, but it's not readily available, but that's your gold standard in looking at causes of shortness of breath. But in a patient with long COVID and post-exertional malaise, that may actually worsen their symptoms. So good history and physical, maybe a chest x-ray, measure their oxygen levels, and consider pulmonary function testing.
Excellent. Most breathing difficulties in long COVID have been labelled as breathing pattern disorder. Can you please explain this term?
Breathing pattern disorder is really a condition where the normal pattern of breathing gets disrupted. Now, like you mentioned before, that dysautonomia, so messing up your autonomic system that you don't really even think about. So this is what breathing pattern disorder is. It causes symptoms like breathlessness, and it's really inefficient breathing. And it can be related to hyperventilation or very shallow ventilation, irregular breathing patterns that can be triggered by activity or stress or anxiety. And it really affects the patient's quality of life and their functional status. And I think of this as a chronic or recurrent condition where your normal pattern of breathing or biomechanical pattern is disrupted. And it results in shortness of breath and other symptoms that aren't fully explained by what you're doing in your tests or in your exam. And it's not really a disease process, but rather an alteration in the breathing pattern. I actually see this in many of my severe asthma patients. It can coexist with asthma. So it's in that pattern, they are breathing with upper airway, and they may have paradoxical movement of their vocal cords. So for example, when we breathe in, our vocal cords open, but in dysfunctional breathing or paradoxical vocal fold maneuver, when the patient breathes in, their vocal cords actually close. So they don't get air in and they can feel very breathless. In general, breathing should return to normal once our challenge or our exercise or whatever has passed, but a lot of times it just persists. And so it doesn't return to normal. And then you get habitually breathing in this inefficient, dysfunctional type of way, and that can cause some of the breathlessness.
How is breathing pattern disorder diagnosed?
Well, usually in patients that have breathing pattern disorder, the physical exam is normal and your pulmonary testing is normal, as well as your oxygen level and chest x-ray, but there can be clues. On the pulmonary function test, for example, there can be clues on that inspiratory loop at the bottom. So patients breathe in, and sometimes that bottom loop is a little flattened or it looks different each time they do the test. So that might be a clue. But the key is really to watch their breathing pattern in the clinic and with exertion and take a good history. Sometimes if I'm seeing someone and their oxygen is a little on the low side, I may put on an oximeter, which measures your oxygen level, and I have them take 4 big deep breaths and then watch for their saturations to improve. And then when they're not thinking about it, it drops back down to that low baseline level. And that suggests hypoventilation, where they're not really breathing deep. So maybe they're just using their upper chest for breathing. I look for tachycardia and a variety of other non-respiratory symptoms. Patients, they may give you the history themselves. They feel like they can't get any air in. They may do excessive sighing, or they have really aggressive throat clearing repeatedly with you, and multiple symptoms just from walking around in the clinic. So in my asthma population, I actually physically look for vocal cord dysfunction by doing a laryngoscopy. So I have access to a scope and I can watch the breathing pattern change and induce some of their symptoms. And it's common in asthma, but it is also common in post-COVID, we're finding. So do they have voice changes? Are they using accessory muscles or mouth breathing? And there are some specific questionnaires for this too that can be used. I don't particularly use them because I have the luxury of sitting there with them and really honing in on their breathing patterns. But there's a breathing pattern assessment tool, and there's other dyspnea scales that you might be able to use to help you determine if this person has breathing pattern disorder.
What causes this asymmetrical closing of the vocal cords, for example? Has anybody worked that out?
It probably has several causes, and one can be heartburn or reflux. So if patients have a lot of heartburn or reflux, they have that, and they have swelling in the upper airway. They may have a lot of postnasal drip as well as inflammation. And then a stressor may happen, and then the patient breathes in and they don't use their normal breathing techniques, and it becomes habitual. So there are several things that are suggested. Anxiety and stress may exacerbate this condition. Reflux, postnasal drip are some things that go along with that. And usually if you have swelling of the vocal cords, and you can actually tell them, you can look with the scope and tell if it's reflux related. Some people that use inhalers may have extra candida or a thrush or a yeast if they haven't cleared their throat well. So there are other things that can add into why that upper airway may be more swollen or dysfunctional when the patient is stressed.
How can breathing pattern disorder be managed in the community, i.e. primary care?
I send all my patients to speech therapists. If I suspect breathing pattern disorder, again, from the history, and then I send them to the speech therapist, and there are a host of exercises that the patient can do. And I think making the patient aware that this is part of their issue, maybe not total, but part of their issue may be this vocal cord dysfunction or other breathing pattern disorder, and then giving them breathing exercises and teaching them the breathing techniques can be helpful. I encourage people managing what triggered these episodes to start. Is it reflux? Maybe that needs to be treated. Maybe they need to learn to manage their stress, and that could be important. But there are several breathing exercises that can be done, concentrating on diaphragm breathing. And I think as patients, teaching them to be aware of how they breathe. So putting a hand on their chest and on their abdomen. And when you breathe in, really concentrate on that abdomen moving forward, that diaphragm. So breathing deeper. There are also ways you can have patients do, I have them jaw thrust forward if they feel like this, they can't get air in up top and they know they have, I'm suspecting they have rather, this dysfunctional breathing. They can just thrust their jaw forward. That opens up that voice box or the larynx to help get air through. There are other breathing techniques you can do. There's a sniff breath technique, so where patients can sniff in a few times, like 3 times times and then breathe out through pursed lips. I can demonstrate for you if you like, but they just breathe in. So sniffing 3 times. And then breathing out with pursed lips. And that kind of helps open up and get them to train themselves to breathe more normally.
How can a long hauler help themselves with all of that?
If they have breathing issues and maybe they haven't gotten to their primary care provider first, just think about yoga, tai chi, other concentrating on their breathing could be helpful, or paying attention to the patterns. Or are they doing shallow breathing? So there are those techniques if they could do that and see if that helps. If the patient has gone into the primary care provider, teaching them breathing techniques, making sure there's not any additional issue like asthma or reactive airways disease. Potentially you could try an inhaler to see if that makes their symptoms better. Then if it's not clear, then maybe they need to refer on.
Okay, well, you kind of answered my last question, which is, what do you think about practicing alternative therapies such as yoga, tai chi, and other relaxation strategies to help ease breathing pattern disorder? There's no evidence base, but what do you think?
Right. I think it's an excellent idea. I have several patients that go to do that. They have taken yoga classes or specific breathing technique classes and tai chi. And I think it really helps the issue, one, so they can focus on relaxing. One, and then part of these courses or this work also is on appropriate breathing patterns and deep breathing techniques. And so I think the two work together well to try to help with some of their breathlessness.
Great. Are there any key points of this podcast that you would like to summarize?
Well, I tend to follow in our pulmonary clinic the British Thoracic Guidelines on pulmonary evaluation of the patient that comes in from a COVID infection, and just doing basic evaluation, looking at a good history and physical for the pulmonary issues. Simple testing like a chest x-ray or an oximeter reading and pulmonary function tests, or even a 6-minute walk can be first steps. If you find something more severe, maybe a more advanced scan of the lungs might be appropriate, but also looking for dysfunctional breathing patterns and suggesting alternative therapies can help if all your testing in your exam is normal. And I've fortunately noticed that the majority of patients do improve over time. They may not be back to normal, and there may be this is their new normal, but they can learn to manage their disease. And one thing that I tend to do also is consider a pulmonary rehab referral for appropriate patients where they can feel more confident and learn to do specific exercise or specific things in a supervised setting.
Oh, that was just such a wonderful interview, Michelle. We're so grateful that you took the time from your busy schedule to come and enlighten us today. Again, thank you for all that you do for long haulers and the medical profession in educating us on how to manage long COVID.
Well, thank you for the invitation. It's been a pleasure.
Please join us for next week's episode of Long COVID, The Answers. Some questions for viewers and listeners to consider. What are your top 5 takeaways from this episode? How will this episode change your practice or perception of this disease? What will you do to act on what you've learned? Please discuss your thoughts on our social media outlets, Twitter or X, the website blog, Instagram, Facebook, or LinkedIn. Please rate this episode.